Okay, so for my case, this actually a abdominal muscle strain, but it was very closely. So this was a 20 years old female D1 volleyball athlete, one of my athletes, right? So she had sustained this injury a week ago, and a week later she told me about this injury. And then she reported pain at the left abdominal area, just right about. And she had pain with doing sit-ups, and she's the middle of walking and blocking and hitting, created a lot of pain for her. And for daily activity, just getting up from the bed, right? Like laughing and coughing, that was really right. So from my clinical examination, it just a lot of pelvic symphysis and a little bit superior to that, about like an inch long. So this abdominis is, and then one of the confounding, right? And then the area is like there was a cyst, and she wasn't having a regular period, and she'd been missing that for like a couple months. Initially missed that because as a guy, I wasn't really familiar with that kind of stuff. Co-workers, female as a trainer, and then we discussed this. My sport mentor, right? Maybe we should refer this patient to our sports medicine doctor. Our like right, and then we did a whole checkup, and then did MRI, but it was just more like ovarian cyst or any gynecological issues. So no, for recovery, we just progress. We had her rest for about a week, and then we just started her from like basic core stability training, and then I think that's pretty standard. Like like individual drills, and then back to full party. And right now, she's doing great. Yeah.
Awesome. I like that you mentioned into feedback.
Yeah.
That
That.
okay. Okay. I like that you insist. I think as a male, yeah, you don't always think about that. And I had a patient that ended up being a cyst. So I think that's always good to think about moving forward. Oh, I guess feedback, we're not really asking questions.
I think that
How
just
did you
discussion.
how did you determine your return to play? Like when she was ready?
So the doctor told her to rest for a week, so that's what we did. And the basic breathing exercises, the basic core activation, the diet, definitely the DNS part of the stuff. So that's how I started for just abdominal strength. It's very related to everything, right? Like every time you move, you got to use your core. Then we started just some basic individual like passing drills for then, and then when she can like do overhead movement without like pain, because you have the stretching of the fascia or whatever anterior oblique system. And we just started to start hitting, and then incorporating jumping, and then practice. So it took me about like a week for the actual progression.
Okay. She was able to tolerate
Yeah.
playing. Nice.
Did she jump serve as part of your
Uh.
progression?
Yeah. So another issue for her is she from a slap tear surgery. So yeah. So yeah, that's a little hard. She's doing great. She's been serving with no problem. So yeah.
When you were, what was the process once you referred to the sport from like a diagnostic process in terms of ruling out any kind of an ovarian cyst or anything like that? Was it ultrasound or?
Yeah. So that's. I think that was the tricky part because there. And as a female athlete, she was more comfortable with a female as a trainer to go with her to the appointment. So I wasn't there actually, but we did some blood work and we scheduled for MRI. And then on MRI, you could just see the, and I don't think they did ultrasound, but they probably should have. If we just diagnostic ultrasound, we could just see the abdominal fibers, and then it would have been, we don't have that.
You gotta have it. And she was like sitting up and things like that, though, right?
Yeah, that was actually my way of hip flexor strain or rectus femoris strain or adductor strain. That kind of, usually I would have the patient first do a sit up. If the sit up doesn't create pain, so abdominal area like strain. If we just stick to musculoskeletal injuries, right? And then straight like raise, that's more like a rectus femoris focused testing. And then I would have the patient do a kind of like a hip flexion with knee flexed, so to focus more on hip flexor. So that's how I differentiate musculature within the very complicated area. So
yeah. In the week while she was recovering, was she like out of all activity? Were there things that you were able to? And then what were you doing from like an intervention standpoint in that in between period?
For so like I said, I started from core activation. So I started from we've been doing some like dead bug isometrics, right? And then I progressed like general lifting. Like if you're doing squats, right, you're using your core, but you're not actually really doing crunches, right?
Mhm.
So that's another way to work the muscle instead of like creating more stretch or overstrain to the area. So
Did you do anything else intervention wise outside of just therapeutic exercise? Work, ultrasound, like anything like that? Or
not for was a very it was very close to the sensitive area. So usually I my hands there.
yeah.
Even during evaluation, it was like, hey, I have to there, but so substitute stuff just like I work for her. So she's a female, so she did a little more hands-on stuff with so it was just for her to do more hands-on stuff.
And what kind of hands-on stuff did she do? Were you there to like see that or?
I wasn't really there, but every day we come just did like more like a I would say more like a soft tissue, right? Because for abdominal there's not really much massage your abs. I wish we could, but it's a difficult, right?
So if you're on the road with this team by yourself, how are you going to manage a similar situation in the future?
Actually, it was on the road.
Okay.
So we had like games the week we were on the road, and she didn't tell anyone. And then we were away the next week, and then she told me the game. So it was really hard for me to. It was our second game, and then it was probably irritated by the first game, the first day. The return to play, like the decision making was very very difficult because hold her from participation because she was able to the day before, and I didn't have a good reason to say, hey, evidence to say she wasn't able to do that, right? But very hard like area to manage, like we're on the on the road, and then there wasn't a lot of like the resources, physicians, right? So
Any more questions for?
I think this is just a wisdom moment, having been the only female with a semi-professional hockey team for multiple years. If you run into trouble with the sensitive areas, you bring in a member of the coaching staff, because my guys we did have 15-year-olds up to 21. So have them be in the room, actively participating, not on a phone, watching where your hands are. You talk through the whole thing. We're still medical professionals. We've got to get a job done. But I appreciate the sensitivity and the fact that you're very close in age with these people, would be my guess. But we can always find a way to work around it. That's my nugget of wisdom I want to try to impart on you. Don't be afraid to get another medical professional from maybe the other team that is there to help. We usually wouldn't have a problem with that, because I know I would appreciate it.
Perfect.
What hockey team was that?
I worked with the Danville Wings for longer than I want to think about, but full time for 4 years. They were in the North American Hockey League and then the United States Hockey League, and ended up moving to Indianapolis, and that's how we ended up back here in Indiana. Was I moved with the team?
I wasn't sure if was it before are they the Fuel now?
Okay, so those guys are a level up. Those guys drink beer. Mine,
Okay.
yeah, these were the guys that were going to get drafted. The younger kids were going to get drafted. The older,
Yeah.
the 1920s were waiting to get a college scholarship.
Got it. Okay. Okay, well, I'll go ahead into mine. So my patient was a middle-aged male in CrossFit, so about 5 times a week. He also ran Spartan races about or so quarterly, and then he was also a CrossFit coach, and he presented kind of at the superior glute, low back, off to the left side, that would come and go. He noticed it 1 week prior, when he did a snatch, which is a barbell movement, and he became pain afterwards. He did seek treatment with a physician, a disc, and just recommended he do conservative treatment. He denied any. He wasn't really able to bend over, and he complained of just a lot of tightness. Constant pain, rating the pain at 8 out of 10. He wasn't any of the workouts. He just kind of took himself out of it and gave himself some rest. One of the was that he works from home, so he sits a lot most of the day. And through my assessment, I noticed that he had weakness in the glute medius, limited flexibility in the straight leg raise, and in his hip flexors, actually really limited in the hip flexors and quads, but no radiating pain down doing a straight leg raise test. And then I looked at transverse achieve a contraction that I wanted, but he didn't have the endurance, so he lost the test. When I looked at his posterior chain activation, he was definitely hamstring. Kind of figured what happened with that glute weakness. I did some in his wall facing squat. I have them like stand up against a wall, and he on both of those. But he when I had him do just like a standing toe touch, his toes, and he felt a lot of tightness. And then I did a couple of tests just to make sure. So we did a Valsalva and then a slump test, and both of those were negative. I diagnosed him more with like a lumbar strain, but I noticed that there were of the glute weakness and more hamstring and quad dominant, probably a lot of the movements that he does in CrossFit. And I just kind of possibly and since he wasn't really consistent with a herniated disc, there could the amount of activity that he's put himself through could have more kind of considered some bulging of a disc. So rehab wise, we did obviously. So I gave him a home exercise plan to focus on the imbalances. So glute strengthening, reducing or stretching in the hamstring and the like foam rolling and hamstring flossing to make sure we get to more mobility in the and then treatment in the clinic, we focused on a lot of just manual therapy work in that area. I did some dry needling and I added some using a TENS unit and stretching and cupping was really what we did. With my setting, it's a little hard. He was also seeing a physical therapist at the time to supplement or complement what the physical therapist exercise there. And so we kind of worked together to make sure we weren't both doing the same. The physical therapist twice a week and he saw me once a week. He's kind of I saw him for a long time. He did after about 6 weeks of conservative treatment because he would get better and then he would get better and then he would try to return back. But that's the thing too with like my settings, whether or not they listen to me in their workouts is kind of different. So I did have 2 bulging discs. I followed up with him after that, but I haven't heard back from him and he hasn't even been to that. More follow-up for you guys than that, but unfortunately I don't.
How long ago was this your patient?
Was in April.
So he's been out for an extended length of time at this point from your facility.
Yeah.
Okay.
Our question, how does that, like when you have a patient who's also doing like formal PT, do you communicate at all with them? Like how does that process go for you?
I've mainly asked for I remember asking him for the PT to communicate, but he never got it to me. But typically that and then if I'm not able to communicate with the PT, then I just take their word and ask, what are they doing with you there? What does he think, or what do they think is going on? Kind of things like that.
If you were in an organization, how would you expect that to be a little different when we would go with that traditional model of everybody being in the same house?
Yeah, so definitely communication. I have another patient that's actually the hip patient that I mentioned before. I referred her to a pelvic floor physical therapist referral, that someone that I had met, and so I have this physical therapist contact information. So the physical therapist, I emailed the physical therapist, obviously got permission from the client. Some of the information that information that here's what I think it is, here's the tests that have been positive, here's the treatment that we've done so far. And then that physical therapist was really good with communicating what she felt was going on and some exercises that she was giving her. Wish would be more fluid. In the cash-based world, it's a little bit, it's different. People want to hold on to their clients, and don't always have clients' best interest at heart, but they don't want to give clients away. So she probably didn't know me, but the client ended up coming to me just because my prices were a lot better. And so I asked her, you know, hey, what is she doing with you? What is she doing with you in your next appointment? And kind of what are your goals with and seeing the PT? So I tried to include the patient in that. Felt like she wanted to see the PT for and what she wanted to come to me for. Now experience with both of us. Would be really ideal.
So interesting. Like, let's say, I don't know, you were in a different setting, right? Like, I'm sure you'd be a lot more intensive in terms of like therapeutic exercises and things like that. But it's kind of just where the patient is, like what their goals are, like what providers they're utilizing, and then just meet them where they reinvent the wheel there. Like if they come to you for a specific service, like that's kind of what you're going to do. I don't know, just.
Yeah. And I don't, it's not always like that. Sometimes people will come and say, hey, for dry needling, and maybe I'll incorporate a little bit of dry needling, but I'll definitely say, hey, I think this would be a lot better for you. Gosh, and I had a thought in my head, but I don't remember it. But yeah, it's definitely. Also, I try to hands-on treatment and therapeutic exercise, especially more corrective exercise, because I also don't want people to feel like their exercises that they could do at home. So there's kind of a balance there. I don't have a lot of people that come in and we do therapeutic exercise most of the time. It's 10-15 minutes, if that. And sometimes it's coupled with cupping, or purpose that I'm getting at.
Right, like if they come in for the manual therapy, it's like that gives you an angle. And then you can just be like, all right, but then also while we're doing this, like X, Y, and Z would help reinforce all the manual therapy that we're.
Yes.
Nice.
Yeah. And if patients aren't compliant with their home, will then take them through their home exercise program. But I always explain to them, this is why we're doing it is, and this is why we're doing it in the session that you're paying me for.
Yeah.
I want to pay me for that, and you want to have time to do other things, then
Does that leverage work?
Sometimes.
Okay.
Yeah.
I guess my question is, where do you see like different from physical therapists, right? So obviously, like I'm in school, so that competition, right? And but in the real world, like outside world, right? Like I always go to PT, wherever, like recommended by a physician or whatever. It's a name that is very well known, and so what is that differentiates you from like or IV rehab or right? So what is the difference?
Yeah. So that's always been like the biggest is how do I educate the population on what an athletic trainer is and physical therapist in the cash-based world. I feel like really differentiates me is the amount of time I spend on hands-on treatment. Obviously, with cash-based PTs, you're also going to have that one-on-one care, but I feel like I spend a lot more time, and this is from feedback from clients who have been to cash-based PTs, that I definitely spend a lot more time hands-on with manual therapy, or more time doing dry needling. They say when I do the dry needling, they say like more of a pistoning technique where they just put it in and kind of move it around a lot. I'll put it in and then I in for like 10 to 20 minutes, depending on what my goal is. And so those things set me apart. Not spending as much time on the correct and giving them that autonomy to do that at home. So my time for them to do exercises, but again, if it's in the best if they're not doing it at home. Finances, compared to cash-based PTs, I'm probably half the price, maybe more than half, not more than half, but like say like my and cash-based PTs are like $200 an hour, $175 an hour. So most of the time if someone's like, well, what's the difference between me seeing you or me seeing a PT, can do like in the ortho world, I feel like we kind of are pretty, I don't want to say even, but we have a lot of the same training in the world. And so, but they can do manipulations of joints and we can just do mobilizations. So sometimes I'll, yeah, it's something that I'm constantly revising, like how I it is difficult.
And you're in Georgia?
Mm-hmm.
Okay. Is that
Yeah.
Oh, that sucks.
I know.
Anyone have anything else for Alex? Okay, then I'm going to take the reins here. My case was from several years ago because it really left an impression on me. I had an individual who was a very talented at a young age athlete, but he had a really big growth spurt between his sophomore and junior year of high school. And he presented with just, I'm going to say, mild discomfort in his dominant side right hip, resolved with a little bit of manual therapy, distraction. He was fairly balanced when we did the FMS screening, so that wasn't an issue. But he was still actively growing from when we saw him in July. And then in mid-September, he had an episode where he was a punter and he also was a field player. He had to run and kick the ball across his body. He should have just ate the ball. It was then he had a very acute moment of extreme pain, anterior hip, these other red flags. He could not extend at all. He didn't want to rotate. That was actually the final moment where I was able to convince his family to go get more care than I could give. They were very resistant at first because he was exquisitely tender in a few areas on his anterior hip, especially with the fader. I'm like, this isn't right. He's very limited. And they're like, oh, it's just because he's growing. He's just tight because he's growing. And he was tight, but that wasn't the problem. They went in and they had to do a dual procedure, not only on his femoral head, but also to kind of bore out his acetabulum a little bit. So his was a little bit more than just an impingement that they had to correct bony wise. He still has the same problem on his left hip, but he elected not to have that revised. And he did come back after being out the rest of his junior year to participate again. He was totally hands off. They did of my care after the surgeon. They did their own PT. I did not see him again until March, right at the end of from a professional standpoint, he was still, with the basketball team at that point, but he wasn't working out. And they were very close-minded about including the AT until they'd released him. So after he was released, in their mind, to participate again, we ended up incorporating hot yoga because he was so tight. They were so restrictive on what he was able to do for months that we had to really incorporate that specific intervention just to get him moving again. And he, had a full return to play at that point. The interesting thing was, now that he's older, he did share with me the reason why he elected not to have the other hip revised, because it still is uncomfortable for him. And he was getting ready to go to a major university as a freshman and did not want his extracurricular activities limited. I don't, that's the kindest way to say it, because it really affected his reproductive activities. I'll just say that, when he had his surgery, and he said, I'm not doing it, and he didn't. So, and he still hasn't fixed that yet. Probably, he's almost 24 now. He's getting close to probably having that fixed. So how can I help flesh out this case study?
Sorry, Jen, can you clarify? I think I missed it, or it froze. The injury was, or what surgery he had?
Yeah, he ended up having, instead of just that femoral condyle revision to kind of smooth out the flat head so it was more rounded and it wouldn't pinch, he had a huge cam lesion, and they went in and basically, had to redefine not only the acetabulum and kind of shave down the rim, but they also had to fix his femoral condyle as well, because there was so much bony restriction. So no matter what I was going to be able to do with him motion wise, I was never going to get any further. So the injury was actually a blessing, because the parents were like, no, he's fine, he's just growing. They really shut me down on following up and at least getting an x-ray that would have clearly shown what the problem was. Did that answer your question, Alex?
Yeah, so to just refer him, or I'm sorry, yeah,
Yeah, the tough part was the family was very resistant to the referral. For whatever reason, they just would not, probably because he was still functional. And because he was still functional, they're like, he's fine. Which was a tough place to be. I wish I could have just ordered an x-ray and gotten it, but we can't do that quite yet.
And it seemed like they may have had some mistrust in athletic trainers, maybe from
you would think so, but he was child 3. He was the third one that we had, but I think it was all his personality that they thought that he was too high maintenance. I don't know how else to put that. And I couldn't get around that with them. They're like, oh, he's fine, he's able to play. And it's like, no, there's something really here. And they just dismissed it. Matt?
What do we think? Yeah, so the game where he had a pain, and then that's when the referral actually came through. What do we think that was there? Just
he
at all,
he kicked across his body. He literally was running to his right, tried to kick across his body, and that extreme force, I think, just pinched him enough tissue wise, and he had some bony hemorrhaging after that he couldn't move, and that, I think, that frightened the parents enough when he was very limited in his motion and needed to be on crutches. They're like, wow, this is serious. So I wish I could have convinced them better at the time, but I couldn't. So
Turning to sport.
He did play basketball as well. He should have played baseball. He's probably a better baseball player, but he didn't like it. And he could have walked on at Purdue, and he elected not to. I think because of the negative, the long period of time and the negative experience he had, where he wasn't getting treated by somebody he saw every day. He was getting bounced around in the orthopedic surgeon's PT clinic, and he just was unhappy about that whole thing. So anyway,
Did you have any role in his return to play?
after they released him, we had probably a 6-week period of time before he really went back in, and that was good because it was in a preseason, like a pre-summer basketball participation, and then for football as well. Preseason started, they kind of overlapped in that May, June kind of period of time. Anything else, Alex? Adam?
Yes. Yeah. So a lot of athletes are tight, right? In their hips, right? That's a word I don't really like because what you're limited in your hip extension. Yeah, of course they're limited. Like most people are limited to extension, right? And is it because you're limited in internal external rotation, or is it just like reaction of your soft tissues to your limited, like your impingement, right? So it's very hard to take it seriously. It's to work with, hey, my hips are tight. It's just like it's very non-specific, and there's a larger percentage of people like having hip impingement that would just reacting to through their soft tissue like as being tight.
Mm-hmm.
Go ahead and do soft tissue release and then some kind of stuff we can make them, like it comes back, right? And then so my I think my way of like this, like I usually start with like passive internal external rotation. Have the freedom of movement, right? Enough freedom of movement. And then I look at the active internal and external rotation. Their freedom of movement, right?
Yeah.
And then if there's a very big mismatch, right? 50 degrees of internal rotation, but you can only use 10 degrees of then we have an issue, right? But if you only have like 5 degrees of it might be a issue that we can never fix without doing surgery. So sometimes that's where I get frustrated from my athletes right now. What can I do? Well, we can do soft tissue today, but long be more therapeutic exercise based, which they do not want to do, right? Really? Some people, yeah, just renting.
So I guess between between the three of us, we all have some patient compliance issues with this specific case study scenario we're doing. Yeah, Matt, I'm sorry I stepped on your.
No, you're good. It's like sometimes where, right, it can be tough when you get like non-specific complaints from patients in terms, but also like that's where like I really like the hip and groin outcome score, right, in terms of a way to kind of contextualize your function, and then how does that then inform the therapeutic exercises that I'm going to do. It's easy to be like, oh, like that. I mean, it's kind of like when you get like someone with SI joint and then they're like, oh, my hip feels off, and like I can tell you as many times as I want, like, but I promise you your hips are aligned. It's just muscular tightness that feels that way, but like the bottom line is like it feels that way to the patient. Try and understand where that then is showing up in their day-to-day life to impact that, and then try and make it. Yeah.
I will say this, the last 5 months, I would certainly do things a lot differently. Initially, I would have hit him with a PRO immediately, but this was, 6 years ago, almost 7, and that wasn't even on my radar at the time. So I might have had a better influence. We could have gotten him started, but sooner. But I don't think the outcome would have been different because he needed to have architecture work that we can't necessarily do.
And 6 years ago, I feel like FAI was still just like still coming down to the. That's not something that was
It was
being
not.
done 10 years ago. So it was still like filtering down to like we get someone who comes in with hip pain. We're all thinking right away like Fadir and look at FAI and like that way 6 years ago.
Yeah, it's amazing. It's amazing how the practice changes quickly.
Oh, I know. Cool. Here, I'll go ahead. Cool. Nice. All right. My patient is also an FAI patient, although I have the benefit in 22 initially rather than in 2016, 2017. And so he is a breaststroker from Spain. Last year was her first year at our institution, and came in having had already like a year plus of MRI done already at home. Had not been like talked through like what FAI was, and although kind of thought she was like, oh, I got a tear in my hip that like I don't really need to. So that was just like a little bit of an education piece there. But so we had the benefit of having this when she already got here. Wound up doing like a contrast MRI just to get a little bit of a better view of. She did not have contrast initially, and then my initial eval was pretty classic FAI. Still had good internal rotation because she's a breaststroker and she just does internal rotation all day long. So she still had 50 degrees, but when we compared it to the other side was 60, 65 degrees. There. And then when you're doing so much internal rotation, like any limitation there is going to have an impact on 400 kicks a day or whatever. So she was very adamant initially that she did not have been something that was discussed with her. And was really, really resident to kind of go down that. We kind of dived fully into kind of just lots of mulligan hip mobilizations for internal rotation, lots of single leg stability stuff, activation, and kind of working through that process. Then obviously like modifying what she was modifying her swimming a little bit. She also had generalized anxiety and then some nutritional concerns at the time too. So, referring her to our sports psychologist on staff, our dietitian, and trying to address those things too. And we had some thoughts that like, all right, maybe if we address this from a conservative and address all the well-being stuff on the outside, like we'll get her to a spot where she's functional because it doesn't have to do it necessarily. But as the year went on, was just not really doing, like would have times where it would flare up. Performance, she never really felt like she got her kick back to where it felt equal on both sides. Time we got towards the end of her season, at that point we're like, okay, you've been super compliant for. We got the range of motion back, but she didn't feel like she was able to use it functionally in the pool, and she didn't feel like she. So at that point, we kind of revisited the surgical conversation, had her check in with our orthopedic surgeon. We're a little bit more aggressive with it in February than we were in September. And then at that of a lot of her hesitancy around doing surgery was that she was on a full scholarship and felt like she was and kind of getting surgery and missing time out of the pool would be a big step back. By that point, she'd already had a great relationship with our sports psychologist, so they were kind of able to unpack in coordination with us how to carry a team meeting with her and eventually made a decision that she was on board with doing surgery. So we did the surgery last spring. She's about 5 months out now. last weekend, did backstroke and IM. So in IM, she does a little bit of breaststroke, but not a full. And is in about a month when we go to our mid-season, she'll do full breaststroke. So, but doing good overall. It was a long process.
Matt, did you find that she was hesitant to take the next step because she's a foreign national and was concerned about our healthcare system, or was it really more worried about the integrity of her scholarship that she didn't want to do that?
No, I think a lot of it was, I mean, one, I think coming here, certainly want to give our system of care a chance and to see what conservative like care would look like here, right? And she does honestly doing a lot of her, because it was like April, so I worked with her in May, and then she went home and then was like with her physio back home in Spain. So she'd had someone who she was connected with her. I think most of the hesitancy was just like, one, who wants to show up to college and get surgery? And I don't think she was really prepared for that option. So in her PPE, when we started being like surgery, no one's talked about that. Like, what are we doing here? So that took some time. And then I think in February, it was clear that she was just putting like way too much pressure on herself. And we're like, impact your scholarship at all. And like, you've got to make the decision that's what's best for you. And like, very much so like, well, I'm here for the team, which honestly in a individual, hear that all the time from our student athletes. Like a lot of them are very individually minded, which is fine. Kind of decompressing some of that stuff. I think it was less feeling an obligation to the team, and felt like she had to put those interests before her own.
Difference in philosophy between like North American, like in treating FAI, or even like just orthopedic in general. I had this opportunity to go to Ireland, so they sometimes they have different like treatment philosophy, like they don't jump quickly, but I don't know because it's like Europe, even different countries have different like system of training, right? So I was just interested in like I was just wondering like, do you see any like a dip in like Spain, right? Spain style FAI treatment versus style, right? I don't know.
Yeah, I think and I had some good conversations at home. I think we hit the nail on the head in terms of just like the last option, which I mean, honestly, is probably like a good, healthy outlook to have. I think maybe sometimes we're a little bit too quick, or when like people are convinced that like surgery is going to solve their pain, and it's like, well, that's not really what it does. I think definitely that piece in terms of like they weren't as quick to like bring that up as, and then bunch of changes, I would say, in terms of like from like a rehab perspective. They were very along the lot, like lots of manual therapy for sure, but I mean, like we're all going to do lots of manual therapy there in a post-op. And then we're very like core based in terms of just like trying to like think about like the whole functional movement paradigm there. But I didn't think a whole lot handled differently from like a rehab perspective than, it seemed like they did maybe like some more, or they're doing like passive range of motion for like a really, but no, I didn't see any major differences, but she's from Madrid too, so like really big,
How does what kind of access to MRIs? Like, is it pretty easy, quick, and like covered MRI?
Yeah, I mean, right, like, so I'll give you an example. Like we had swimmer who I've been treating for 2 weeks. Actually like a little bit concerned about like she's got something unique about her stroke, and she's a back distal clavicular stress fracture. So I had to see our physician this morning. So she saw a physician at 9 a.m. I emailed our contact. They were like, okay, we can do it at 10:30. At 10:30, and we got the read back now. So like we're pretty like, and we're just like lucky that way, I guess. And this is not, especially it gets a little bit trickier if we're doing like an arthrogram, right? Because then we've got to have someone to do the injection demand we have. But like Northwest, like, so we're all contracted through. And then we have a pretty big like outpatient clinic in downtown Evanston that we have. But if it's something that they're doing in Evanston, it's pretty easy for us. And then on the specialty really on how close of a tie we have. The MRIs are.
Your evaluations, how do you decide, you know, getting an MRI on most things just to make sure, or how do you kind of accessible or easy to kind of, you know, put together? How do you just warrants that or not?
Yeah, no, we're pretty judicious. I mean, it's gonna, and that if you looked at us across our patient panels, I think that might be an area where like is the same, you know, like I think to be frank, it probably makes a difference if they're a full. The standpoint of like the benefit or whatnot, I just think like some and a physician are going to make different decisions for different patients. But for us, we're pretty. See someone with shoulder pain, I'm like, okay, cool. Like you have a slap tear, or I suspect you have a slap tear. Like you for years, we're not going to jump right to surgery. So if we're not going to jump right to surgery, and that's not going to be optional, we're going to for at least 4 weeks or so and see how we're doing. And then if we're not making progress, then get imaging. Like I think if it's not going to inform the care that we're providing, why are we going to do it? You know, like difference maker where versus like then a patient who I've been rehabbing for 4 to 6 weeks and we've been modifying their activity. Now knowing that it's a slap tear, now we might do an ortho consult, but like we're not going to jump right to that bridge anyway. So we try and be judicious with it, but they get an MRI than a patient in the general public.
Access to care to like X-ray, MRI, like changes you like your skills or because I think it changes my evaluations. We can see doctor every Monday, so hey, I mean, if in doubt, like refer to doctor. We can get MRI the next day or whatever on the day, right? And then that's job doing evaluation. It's just like sometimes it feels I'm cheating a little bit. From a D3 school, I mean, as a student, right? We had to do rehab for 2 weeks, and then we can see that about getting an MRI or X-ray because it was a D3 school. So I don't know.
Yeah, and I think that's going to be. I mean, my thought is that's where you've got to right and understand, and they've got to know how you're going to practice. You've got to understand how they're going to practice, right? Like someone comes into because it's like, listen, like you can see Dr. Stevens, but like she's going to want you to do X, Y, and Z with me about anything. And like her and I have, but we've been, you know, this is my 4th year. We've both been working together for 4 years. So like they're really well. And like, I know where we're going to go with an eval and what the steps are going to be, you know? So I think that, and then also knowing that like, you don't want to use it as a crutch in terms of just like, well, it's okay, so I'm not going to make, you know, like you have to make clinical decisions, right? And you got to like try and challenge yourself to like clinical decisions. And when you do have them see a physician to say, hey, here's what I'm seeing on my evaluation. Here's what I think possible next steps might be, or here's what I'm looking for from this appointment, you know, and that's where it's like, rather than just like putting them on the doctor's schedule to be like, all right, I don't know what's going on with this. I just need you to look at this and figure out what's going on and tell me, you know, like try and challenge yourself to have what are you looking for out of that appointment with the physician? You know, if it's like, hey, I listened to their lungs and I think that they might have a pneumonia, I want you to take a listen and see if antibiotics are, you know, like have those thoughts in terms of like, here's what my clinical evaluation is and here's what I'm concerned. You know, I don't need to rant too long, but you're right, it can become a crutch. And so you just have to like utilize it as a learning resource where it's an easy way to get your evaluation skills double checked and get live feedback rather than a way to let your evaluation skills diminish.
So certainly to use it more as a verification of your thought process.
Yeah, and to be like, hell yeah, like I listened to those lungs this morning and I thought I was a pneumonia and it is a pneumonia, like I nailed it. Hell yeah, like, you know, like, and then you just get more and more confident on stuff, things like that. I don't know, does that make sense, Adam?
Yeah. Because I just got started, you know. So at the D1 school, try not to get spoiled, but you know.
Yeah, and view it as a great way, right? Like that's not like, and you can become a great AT regardless of what setting you're in. But that's a benefit of like just looking at your setting and being like, oh, cool, I have this way to get live feedback versus, you know, if you're at a high school and you say you should go check in with your pediatrician, you may not hear back from them and you may not really get the conversation back in the way that you can at the D1. So, and not that there aren't better learning opportunities at a high school, but you've got to look at your situation and find the learning opportunities that are unique to it.
Does anyone have any final comments or conversation for Matt?
Nope.
Thoughts about the whole evening here?
No, this was fun. I enjoyed this.
Yeah, it's cool to hear other perspectives and just stories.
Absolutely. Adam, do you have anything?
No, I think we covered like different like parts of the lumbar pelvic hip complex, right? Like it's complex, right? So like an abs and glutes or the back or FAI, right?
Mhm.
So.
All right. Well, without further ado, then I will go ahead and pause the recording. Thank you for your time this evening.